One Friday night, Bob the X-ray tech was working at his favorite place of employment, the PSL emergency department, with a first-year radiography student when an order printed off the printer. It was a 3-view hand X-ray. Excellent, Bob exclaimed. A great teaching moment for the student currently working with him. Bob and his student grabbed their digital portable machine and race off to the emergency department. Outside the room, they see that this patient has been placed on contact precautions for MRSA. Bob explains to his student that MRSA is highly contagious and is one of a host of diseases that are common nosocomial infections, otherwise known as hospital-acquired infections. He explains that in order to protect themselves and other patients in the hospital, that they will need to wash their hands before and after seeing the patient, don gloves and a gown, and clean their machine after they finish. After putting on the appropriate PPE, they enter the room where Bob proceeds to go through AIDIT and explains that the doctor has ordered 3 X-ray images of his hand and that he would walk him through the entire process through demonstration and positioning. Furthermore, Bob took a thorough history from Mark and found out that his hand has recently been hurting. Mark seemed nervous, so Bob asked if he had any questions before they started the examination. He said that he was somewhat hesitant about getting X-rays because he had heard that radiation causes cancer. Bob explained that while ionizing radiation is not good for a person, the doctor ordering the exam has determined that the benefits far outweigh the risks. He then goes on to assure the patient that they would do everything in their power to minimize the radiation he received, by using lead shielding, collimating to the area of interest, and taking as few images as possible. This explanation reassured Mark, and he agreed to go through with the exam. The patient was then given the appropriate lead gown. Bob then had a student positioned for the PA image of the hand. After the student position, Bob checked his student's work and ensured that the SID was 40 inches away from the IR, and that the collimation was 1 inch on all sides of the hand and included anatomy 1 inch distal to the ulnar styloid process. Before taking the X-ray, Bob set the technique to 58 kVp at 0.8 mass. The student was confused by this and asked how such low technique could be used. Bob explained that this technique selected is always dependent upon the body part being examined and the patient's habitus. He further explained that because they were using a digital image receptor, which has a large dynamic range, they could use a higher kVp and less mass than what would be necessary for a film screen system. This selection of high kVp, low mass helps to reduce patient dose. Bob also selected the small focus spot in order to maximize detail because such a small body part was being imaged. Before taking the exposure, Bob ensured that both himself and his student were as far away as possible from the X-ray source because distance was the best way to decrease occupational dose. After taking the exposure, Bob examined the image and obtained and saw that all the anatomy of the hand was present and in the correct PA appearance. He was sure to inspect the image to be sure that there was bony trabecular detail along with an acceptable exposure index number. This assured him that the technique selected was optimal. Next, the student positioned the patient for an oblique hand where the hand was rotated laterally 45 degrees to the image receptor. The patient was unable to hold this position without shaking considerably, so the student grabbed the radiolucent sponge and used it to steady the hand and keep it in the correct oblique orientation. This reduced the chance that there would be motion on the image, which would decrease detail present. Before making the exposure, Bob increased the technique slightly because when a part is oblique, it increases the thickness of the part slightly. After making the exposure, Bob again examined the image and saw that the hand was oriented correctly as the digits were separated and there was no overlap of the soft tissue of the digits and that there was minimal overlap of the 3rd, 4th, and 5th metacarpal bodies. Next, the student positioned the hand for lateral projection, ensuring to use the fan lateral method as was protocol for this particular hospital. Bob double-checked the positioning after the student was done to ensure that all the fingers were not overlapping and were parallel to the IR. He did this to ensure that there was not any foreshortening or elongation of the phalanges due to having the part angled towards or away the IR, which would lead to distortion. Bob again increased the exposure slightly because the part had been placed in the lateral position. He then made the exposure and ensured that the image met all the necessary requirements and was thoroughly satisfied with the student's work. The fingers were all clearly separated and the metacarpals were superimposed along with the distal radius and ulna. This told Bob that the patient was placed in a true lateral position. Upon finishing the examination, Bob thanked the patient for his help throughout the exam and explained that the images they took would be sent over to a picture archiving system known as PACS from which the radiologist could look at them and dictate a report for his doctor to see. Bob asked if Mark had any questions, and he said that he actually was curious as to how the machine worked. Bob explained that the mobile X-ray unit is operated by a large battery, which through a series of different circuitry allows for the amount and strength of X-ray photons to be selected for based upon the current and voltage directed to the X-ray tube, which has a negative side turned the cathode and a positive side turned the anode. Within the cathode side of the tube, the selected electricity is sent to a filament made of thoriated tungsten, where the electrons are boiled off and create a thermionic cloud of electrons. When the X-ray switch is pushed, the circuit is completed, and this allows for these electrons to shoot across a small distance to the anode, which is a rotating angled disc composed of molybdenum and tungsten-rhenium alloy. When the electrons strike the anode, they are immediately forced to stop, and thus 99% of their kinetic energy is transformed into heat, but a small amount of it interacts with the molecules on the anode's surface to create X-ray photons, which are emitted downwards thanks to the angled shape of the anode focal track. Only a portion of these X-ray photons are allowed to exit the machine due to the collimator box, which has lead shutters which correspond to the light it emits to simulate where the photons will be directed. These photons exit the collimator down towards the hand. Some go through your tissue, but others do not, and this effect is what allows for an image to be formed. The image receptor underneath your hand contains a multitude of small pixels, which sense whether or not they are stimulated by the X-ray photons, and thus produce an image based upon how many photons strike them. The patient looked up at Bob thoroughly confused, but adequately satisfied with his explanation. He thanked him for taking such great pictures and wished him a great day.